Right now, we're moving to Jay Bhattacharya. He's a medical doctor and professor of medicine at Stanford University. And Jay is really quite the package. He's a medical doctor. He knows a lot about the health impact of the virus, and he was considered an essential worker during the height of the pandemic. In some senses, just like David, these guys are going from the lab, as it were, to the hospital. But he's also has a doctorate in economics. So he's done a lot of thinking about the weighing up of the economic costs of our response to the virus, and in particular the wider health impacts of economic failure. One day after David Katz had written in the New York Times, Jay wrote a piece in the Wall Street Journal which was countering the claims of presidential advisor Dr. Fauci, who had been citing a death rate that forecast up to 4 million deaths in the US. His courage and his willingness to consider the data deep and wide is why we're fortunate enough to have him with us today. Jay, over to you for your presentation, and we'll take questions at the end.
Oh.
Jay, there?
I'm here. It's a real pleasure to be here. Thank you for having me. And I should clarify, unlike David, who actually takes care of patients, I've spent my essential worker credentials in the lab. So,
right.
Anyway, so with that aside, I have some slides I'd like to share, and I hope folks can see them. Just to give you my perspective and point of view, and also to put things in perspective that in a way that I couldn't do without the slides. So COVID-19 in New Zealand, in some ways, is a remarkable thing, because the number of cases that New Zealand has experienced is incredibly low relative to the rest of the world. And in a way, because of that, you've missed the how deadly COVID-19 infection actually can be. Part of that, I think, also is interesting, because the perceptions of how deadly it is don't correspond to the actual scientific data. So I'm going to run you through some of the considerations on thinking about how deadly it is, and show you the data about it. Then I'll turn next to the economic damage from the lockdowns, and I'm going to put it in a New Zealand context just to give you some sense from the forecasts that have been put forward. And then I'll end with just with talking about policy. All right, so how deadly is it? So the key distinction, and I apologize if you all have already seen this, but I want to make sure that it's clear in everybody's head. The key distinction is between the infection fatality rate and the case fatality rate. The infection fatality rate is the number of deaths among the infected divided by the number of infected. The denominator is the total, all the people who have been infected with the disease. The case fatality rate is the number of deaths among the cases divided by the number of cases. Well, it looks like, if you look at it, it looks exactly the same, but it's not, because a case is not the same thing as an infection. A case is somebody who, as a patient, who's been identified either by public health authorities or by a hospital or by someone as either probably having COVID or confirmed to have COVID via PCR test or some such thing. There's the selection problem is enormous there. The set of people who get tested is not a random set of the population. Completely reasonably, the tests are reserved for people who doctors think actually have COVID, or people who suspect they have it or have some other good reason to be checked. It's not universal. I mean, there's no way to do a universal PCR test of the entire population. And even if you manage to do it one day, the next day you'd have to do it again, because the PCR just checks to see if you're currently infected. The number of infected people may include a much larger fraction, in fact, a part of the population. And in fact, the evidence suggests that is actually true. Now, if you want to understand how deadly is the disease, you want to know what the infection fatality rate is. Like you, a random person in the population, me, a random person in the population, if I want to know, well, if I get it, how bad is it going to be? How likely is I going to die? Well, you want the infection fatality rate. The case fatality rate tells you, if I get it, and I end up in the hospital, just like David was saying earlier, I end up in the hospital and I get a severe case, well, what fraction of those folks die? Okay, in the U.S., in the early days of the epidemic, the initial forecast suggested an incredibly high case fatality rate. The World Health Organization thought it was 3.4%. There was a paper published in the Journal of American Medical Association analyzing Chinese data saying it was like 2.3%. Those are enormously high numbers. Those numbers suggest a deadly disease. And actually, To some extent, the deadliness of the disease has been borne out. If you get this severe viral pneumonia, it is deadly. Upwards of upwards of 4, 5, 6% of the population that end up in the hospital or can die from it. If you end up in the ICU in the early days of the epidemic, 90% of the people who ended up in the ICU with a ventilator died from it. And so people looked at this, they looked at the pictures, and they thought, gosh, we better do everything we possibly can. Again, a not unreasonable response in the face of numbers like this. The problem is these numbers and those pictures present a very, very misleading picture of the full scope of the epidemic. They present a small fraction of the most severe cases and pretended as if everyone is at risk of getting exactly that, when in fact, there's a very large number of cases where there's no symptoms at all or very, very mild symptoms. Let me show you some evidence for that. And that comes from seroprevalence studies. So what is a seroprevalence study? Seroprevalence study, instead of looking to see if you actively have the virus in you, the seroprevalence study looks to see in the population of interest, what fraction of the population has antibodies to the virus. Well, antibodies, they fade. We now know they fade over time, but the rate at which they fade is unclear. But they provide evidence that you actually were infected even after you've cleared the infection. This is not like HIV or even like chickenpox, which hangs around in your body forever. These viruses, just like common cold viruses, get cleared out of your body if you survive them. And the question is, what fraction survive them? So the seroprevalence study, what it seeks to do is it says, okay, let's look at this population, draw samples from the population, and see what fraction of the people in the population chosen to be at least somewhat representative of the population. It's hard in the midst of an epidemic to get a fully representative sample, but it's certainly more representative than case number reports. Well, what fraction of them have it, and then extrapolate that to the population at large, from the sample to the population. This is completely standard methodology. I should say a couple of notes about seroprevalence studies. They almost certainly, at this point we know, provide an underestimate of the total number of cases, because there's evidence that there's some people react to the virus with a T-cell mediated immune response with minimal antibody formation. And as I said, the antibodies fade over time, so we might catch you too late. So we're going to still underestimate, but this is still better than just going by case numbers alone, which turns out by order of magnitude. So the question is, like, what are we finding? In the early days of the epidemic, I worked on probably one of the very first seroprevalence studies. Since then, there are now somewhere on the order of 50, 40, 45, 47, 48, something like that, papers reporting on seroprevalence data, and many, many more not put into paper format. And I'm going to just show you a few of them here. In fact, I just want to run you through a couple of the numbers. These are drawn from a study that John Ioannidis, who's a professor here at Stanford, has done. Basically, he's been collecting these numbers, collecting these studies. Now, what you can do with the seroprevalence studies, you can actually get a better measure of the death rate, the infection fatality rate, than with the case fatality rate. And now, since there's been 45 studies, I have a lot of these. These are all from John's meta-analysis. Let me just run you through what they found. And I won't go through every line because it's not worth your time, but I'll just point out a few highlights. So in Iran, for instance, in early April, 33% of the population was found to be infected, have antibody prevalence. That would imply approximately 770,000 people had been infected as of early April, orders of magnitude higher than the number of cases that have been identified in Iran for that. If you look at the number of deaths, 2 weeks before, with a 2-week lag, 2 weeks after rather, so that you can figure out what the death rate is, because it takes a couple of weeks to die, given that you develop a severe case. Well, it turns out, but 0.07%. What is that? That's 7 in 10,000, or 0.7 in 1,000 deaths. How much would you change your life? Would you stop sending your kids to school at 7 in 10,000 probability of death? In Boise, Idaho, there was a study done in late April. 1.8% of the population. Again, that looks like a small number, but Boise, Idaho is a small town, and that turns out to be much larger than the number of cases identified in Boise, Idaho at that time. And the inferred fatality rate is 0.13. So 1 in 1,000. Among people who are under 70, it was 2 in 10,000. 2 in 10,000. In Japan, 10.9% of the population, 1 in 10,000 for the under 70 population, 2 in 10,000 for the population at large. I said I promised you I wouldn't go through all of them, but I wanted to highlight a couple more. New York, 14%, represented in April, representing 2.7 million cases, and a case fatality rate among those under 70 of 3 in 1,000. In China, 8.4%. Remember, in Wuhan itself from March to April, with a inferred infection fatality rate of 0.4%, 4 in 1,000. Remember, the early estimates from Wuhan itself were 3.4%. This is 10 times fewer. The CDC conducted a study in the United States of six cities from commercial labs, and they also found very low rates of mortality among those under 70, and even over 70 overall. They found, in Utah 0.08, Connecticut 1.5, a very high rate. I'll show you a few others. The median mortality rate, the median infection fatality rate in these studies was 0.27%, somewhere between 2 and 3 in 1,000. And for those under 75, it was 0.05%, 5 in 10,000. Okay, so what can we learn from this? First, the disease is much more widespread than the official case numbers would suggest. It's less deadly for the general population than for us, than the case fatality rates imply, especially for those under 70, though it's obviously still a very deadly viral disease for those who develop those symptoms. A very large fraction of the people, maybe half, maybe more, who are infected experience only mild cold-like symptoms or no symptoms at all. That's the typical normal presentation of this disease. What you see in the newspapers, what you see in the video is the worst presentations of those disease, and those are terrible, and we should seek to avoid them. But we should seek to avoid them by understanding who's most likely to get that presentation. That's people set 70 and over. The other thing is the fatality rate is a function of the last thing I should have put on here is that fatality rate is a function of both the host and the virus. It's not a single number, and it depends on the circumstances of treatment. So in places that are overwhelmed, that are managing the patients improperly, you're going to get high death rates. In places that have the resources to manage the patients they have, even the more severely ill patients, with the better knowledge of how to manage the disease we now have, you're going to get much better looking numbers. Okay, let me talk about flattening the curve versus eradicating the disease. Now, the whole policy has been to try to avoid this light blue line. Without protective measures, the dashed blue line is the capacity of the healthcare system. This is the notional curve I'm sure you all have seen. You get a number of cases that is above the dashed blue line. You've overwhelmed the healthcare system, you get mass death. We've seen that. We see that in Wuhan. I think to some extent we saw it in New York. If you have protective measures, you flatten out the spread when the disease happens, and so you never exceed capacity. The point I want to make is that the area in the light blue line is the same as the area in the dark blue. The same number of cases eventually happen. The only question is when. There was a very interesting paper, post, and I assume paper by two mathematicians, Chiquita and Pegden, who they labeled the paper a call to honesty in pandemic modeling. They re-evaluated models like the one that led to the lockdown policies. What they said was, okay, well, you have a flat curve as long as you have the lockdown. But what happens after you remove the lockdown? Well, you see a very, very sharp increase in the number of cases. The models imply that you're not eradicating the disease. The models imply that you're just delaying when they happen. You either pay the cost now or you pay the cost later. So the lockdowns are not a mechanism for disease eradication. They'll only delay when the disease happens. Okay, and I think the experience that Auckland is having right now is evidence of that. Now, while it's not yet certain exactly what led to the outbreak, and I know there's theories of containers from abroad and so on. I'm sure we'll learn more about it in coming days. One possible idea is that the disease was spreading sub rosa basically in the population, even despite the lockdown, there was present. Though you think you've eliminated it because you have no identified cases, most of the people infected have very mild illness, and they may not know that it had it. So it could have just been spreading around. I actually searched for a seroprevalence study for New Zealand. It would be very, very interesting for New Zealand to do seroprevalence studies and continue to do them to track exactly how widespread the infection actually is, as opposed to the current numbers, which don't tell you that. Let me finish with some notions about economics, and I want to emphasize the epidemiology economics trade-off. And the theme in this last part is about lives versus lives. And the reason why I say lives versus lives is a lot of times people try to say that, look, we want to save lives. They're incredibly valuable, which is true. We should pay any cost whatsoever so that we can protect the people from dying from COVID. The problem is, and so folks who are skeptical about lockdowns are put in a corner to have to defend the economic gains versus the lives, and I don't think that's the right argument. The right argument is, and the right facts are, that the economic costs themselves have consequences for the lives of people. Poorer countries are poorer, have shorter lived peoples, and there are real health harms from the economic harm caused by the lockdown. So I have three propositions I'm going to defend here. Proposition number one, this should be not at all controversial, which is that lockdowns slow the spread of the epidemic. We've seen that in New Zealand, we've seen that around the world. Lockdowns are an effective tool to slow the spread of the epidemic. Not eliminate the disease, but to slow the spread. Proposition two, the more severe the lockdown, the more severe the economic harm. That, I think, is also indisputable. Proposition three, economic prosperity improves population health, economic devastation kills. It's not lives versus dollars, it's lives versus lives. Proposition three is well accepted by health economists, and I think is pretty non-controversial, although it may be surprising to some. Okay, so let's look at what the GDP hit is of the, this is from Stats New Zealand. I pulled the GDP hit of the, and what you can see is a very, very widespread economic damage between December and March, from the first quarter lockdowns alone in New Zealand. The only folks industries that escaped are mining and information, media, and telecommunications. The construction industry was hardest hit. The retail, trade, and accommodation, transport, postal, and warehousing. So the tourist industry was enormously. Here you have I pulled some numbers from the UN Comtrade UN database on exports, and you can see that in 2018 there was about $10 billion in people visiting New Zealand and spending money in New Zealand. That's an enormous fraction of the New Zealand economy, which is about a GDP of about 200 billion. So it's just to get some sense of how large the actual number here. 208 billion. This should say billion. Yeah, so this 10 billion is an enormously large number, a fraction of travel. And here's daily border crossings. Since March, there's been very, very few. The tourist industry's collapsed. That's $10 billion that evaporated. The question is this permanent, or is this just a temporary measure? I think that given the current trajectory policy, this is more or less permanent, because if you want to protect New Zealand from all cases forever, you can't have travel. You can't have people coming in from the outside, because they'll bring the cases in, as you've seen already. Okay, what I plotted up here is I've taken New Zealand's IMF growth forecast for 2020. In fact, I've done it for a variety of richer countries, versus the number of COVID-19 deaths as of yesterday. Per million population. New Zealand is up over here on the top. New Zealand is they've had very close to zero deaths. On the other hand, economically, New Zealand, you should be as David said, don't compare yourself to the U.S., which has had an absolutely horrific response to the virus. Compare yourself to the countries that are up here. Greece had a worse economic outcome with roughly the same number of deaths. Korea, Singapore, Taiwan, Japan, Hong Kong, Slovakia, all Czechoslovakia, the Czech Republic, all had better economic outcomes with roughly the same number of deaths. So New Zealand has done well, but as far as limiting the deaths to date, and has the opportunity to continue to do well, but at great economic cost, about 7% GDP hit. So what does that mean? Well, when you're poorer, and the lockdowns themselves have all kinds of effects. It's higher suicide rates, domestic violence, derailed education. Now, for the most part, New Zealand has avoided that because they've been able to lift the lockdown after the number of cases went to zero. The lockdowns, if they come back, these consequences will come back. What I'm going to focus on here is shorter lifespans, and shorter lifespans arising from the economic hit. So what I've done is I've plotted for New Zealand from 1961, which is over here. This is income on the x-axis and life expectancy on the y-axis. And this is from Gapminder. I just tracked how New Zealand has fared in terms of life expectancy and income. And you can see New Zealand has done very well since 1961, with life expectancy going from 71 to almost 82 in 2019. And income per person going from about $16,000 per person to about $36,000 per person. Enormous progress by any standard. So 36,500 per person, 82. That's how New Zealand was last year. It's a success of the healthcare system, a success of the economy. New Zealand, I would say, I would grade as an A+ if I had that kind of authority. Okay. Well, what does this 7% annual growth rate hit mean? Well, it translates to about a $3,000 per person loss in income, or 4,500 New Zealand dollars per person loss. Well, if we go back, how far back do we have to go before we get the $3,000 loss? Turns out it's 2012, right? 2012, there was $33,300 of income per person, and a life expectancy of 81. The economic harm from 1 quarter of lockdown wiped out 7 years of economic progress, and in the long run likely will wipe out at least 1 year of life expectancy gain. You're getting loss of life in addition to the economic harm. It's not just dollars for lives, but lives for lives. There's a very rosy forecast for 2021 for the whole world put out by the IMF. It forecasts that New Zealand will have a plus 6% growth rate up over here. I hope that happens. But this happy scenario was developed before the latest lockdown. Repeated lockdowns, if they happen, will mean that New Zealand will do economically worse than the rest of the world that have stopped locking down. And it seems likely that much of the rest of the world won't be in a position to lock down. Okay, thank you for your time. That's all I have. I say for the policy going forward, we know a lot about the disease now. You protect the older population who are most vulnerable from dying, and then let the rest of the population who face relatively minimal risks from the disease. I mean, not no risk, obviously, it's a deadly disease still, but relatively minimal risk from the disease go about their business, because this is not a let's protect people at all cost situation. It's a question of trade-offs. Thank you.
Right. Thank you, Jay. And thank you enormously for that work you did at the end there on New Zealand specifically. Really appreciate that. And, you know, I think although we've talked about some numbers here in New Zealand, actually seeing it there 7 years lost with 1 quarter and 1 life year lost is quite stunning. I'm going to start, if it's all right, in terms of questions, taking you up on the seroprevalence studies, which were it's incredible work. I'm not sure if you're aware. You said that you looked for studies in New Zealand. The thing is, we haven't done any. We've done no studies here whatsoever. The government has not done them. I think it may have been asked once, and I'll probably do injustice to the answer, but it seemed to suggest that we would just know about prevalence via the case rate, which you're obviously suggesting wouldn't be the situation. Have you got comments on that? Just that for itself, about the fact that we haven't done these studies?
I think it's really hard to make good policy without knowing actually how widespread the disease is. And so this is what's motivated my work on seroprevalence, is try to just paint a much better picture of how big the iceberg actually is. If you just looked up in the top and you say, okay, I'm going to crash into the top, and you're going to miss everything underneath, you're going to make bad policy. I think that it's a very good investment. They're not expensive to run. and they would provide an enormous amount of information for New Zealand, actually for every country on earth, I think, in how best to manage it.
Would it be too late for us to do this?
No, it's not too late at all. I mean, I think if you understand how many people have actually already been exposed, you might even get a better sense of how likely it is that there's still reserves of the population out there. There's, I think, a debate happening in New Zealand right now. Did the new cases, I think what now, 70 new cases, come out from the outside in, or were they homegrown? It would help provide some evidence on that question, for instance, and then just guide policy better.
You touched on that briefly. Do you think then it's very possible that that after 3 months of no cases that this could still be homebred? It's
quite possible. I mean, I mean, I obviously can't know until you've done until all the work's been done. But I think there's no reason not to believe that person A has it with a very mild case, passes on to two people among the young. They have it. You don't end up seeing it, and you're not looking for it because you've solved it. There's 120. So someone dies of a pneumonia that you don't necessarily record it as COVID. I mean, it doesn't look. I mean, not every COVID case looks exactly alike. I mean, it's not like it's certain that that's what's happened, but it's certainly a possibility.
All right. The reliability of data. I mean, you're working a lot with data. It seems as if we've been caught out internationally, either in recording of cases, recording of deaths. Could you comment on how reliable data is? Was it at the start? Is it becoming more reliable? Can we? I mean,
it's hard to comment on that universally. I mean, part of the issue, for instance, in the United States, if you're a hospital seeing a patient with COVID and Medicare, the over 65. You get paid a 20% bonus on the case relative to if you're not seeing a non-COVID case. So there's strong incentives to over-report in some settings. In other settings, you may end up missing, as I said. So there are certainly data quality issues. The other issue is like whether you call a case a COVID case or not. So do you need to have a PCR positive to call it a COVID case, or can you diagnose it on the basis of symptoms that look like COVID? And countries differ in how they're treating that. Some are requiring a full PCR positive to say, yes, it's COVID, and some are saying, okay, a probable COVID case should be counted as COVID, whether there's PCR verification or not. So this is definitely an issue where international standards will be helpful. This is something like it's a group like the World Health Organization could play a really important role in sort of regularizing how we do report around the world.
I'd like to explore a little bit more around this economic cost. You gave some great assessment of the things that happen due to economic downturn. It has been interesting to see the same people who claim that economic improvement helps improve quality of health and lifespan also now say that there isn't going to be any losses from the economic hits we've been going through. But I just wonder if you could kind of explain, by way of example, perhaps, how that direct connection happens between the economy and health discrepancies.
There's a lot of an enormous literature. This is one of the favorite topics of health economists to study. So for instance, education is a good example of this. When we are poorer, we invest less in the education of our kids, and that has lifetime consequences. The more poorly educated kids have worse, in the long run, when they're older, have worse health behaviors. There's fewer resources available to take care of the folks when they get sick. Investments in health are enormously profitable in improving health. So it's not surprising that when a country is poorer, it invests less in health, you're going to get worse outcomes. There's 100 mechanisms, all incredibly well documented. It surprises me that this should be seen as a controversial topic. Investments in health are worthwhile, especially in places like New Zealand that take pride, justifiable pride in their healthcare system, and the investments that you all have made in your healthcare system. And the returns from that I think are quite evident in the high life expectancy and the high quality of life you have. Reversing that, how can it not reverse that? I mean, it seems like not a controversial point.
Okay. Perhaps comment also on the international the international impact. And by that, I'm talking about the developing countries, poorer countries. I know you've had a bit to say about the way in which the Western world has gone into its shell and almost broken its connections with the developing world. Could you explain a bit more about that? How has that happened?
Sure. I was going to say more about that in my remarks, but I sort of ran out of time with all the slides I already had. I think that that we have a compact. So, for instance, there are organizations like the World Trade Organization. We made a promise to the developing world. The developing world has made a promise that, okay, you join the global economic system. We'll have mutually beneficial trade, and it'll enrich all of us. And that's like a classic theorem in economics, and it's played out. Trade is a really, really good thing. New Zealand's benefited enormously from trade. Countries around the world have. Essentially, what COVID has done is it's created autarkies of every single country. And the worst hit are going to be countries like our poor countries that rely on the promises we made of them. We're already seeing around the world a huge reduction in a huge increase in tuberculosis cases, untreated tuberculosis. We're seeing malaria reduction programs stopped because of lockdowns and COVID risks. We're seeing vaccination campaigns like Gavi shuttered for the time being, again for COVID. We're going to see a resurgence of these diseases that we thought we had suppressed all around the world. And I view that as a failure of the developed world and the promises it has made to the developing world. Because we're so scared of COVID, we're gonna end those we're gonna violate the promises we made about the benefits from global economic cooperation. In effect, we'll turtle up into our shells, protect ourselves from COVID at the cost of enormous suffering in developing countries as they get poorer and less healthy. And I think the trade-off is such a bad one because it's not like we also will face those costs in our own countries as we become poorer. So I think this is one of these things where like it's hard to get a full accounting of the number of it. I mean, I'm trying to develop an accounting. Maybe at some point I'll be able to put something convincing together. But the direction and the magnitude seem pretty clear to me. Of the harm that we're doing to the developing world from these lockdown policies we've adopted.
Thank you. We've got time for some more questions, and there's a whole lot of them, Jay. There's a few questions there about the accuracy of the tests, the accuracy of testing for whether or not you've got COVID. There's a number of them around it being possible to test positive but not harbour a virus. Could you comment on that? Are there different tests? Is there different?
Yeah, so those are all good questions. So the antibody tests, in the early days of the antibody tests that were available, there are two kinds of tests. There are these very, 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 very accurate ones with which you can draw blood, and they're called ELISAs. They're like 99+% specific, which means that you have very few false positives, and they're 95+% sensitive, which means that they have very few false negatives. There were also these like small test kits, very cheap test kits that had a wide variation in accuracy. Some were very, very accurate, and some were inaccurate. Some of the bad black eye that seroprevalence studies got in the early days have to do with the fact that some of the studies were run with relatively inaccurate test kits. The one that I ran, for instance, Santa Clara study, it turns out that the test kit we used was incredibly accurate. It's now FDA has approved the technology, for instance. But in any case, even with an inaccurate test, it turns out that you can do statistical adjustments to adjust for the inaccuracy as long as you understand what it is. The seroprevalence studies that I reported on all those papers, many of them are peer-reviewed in the scientific literature. They tell the same story over and over. The virus is more widespread than you realize, and the disease is less deadly than you realize in every country, in every state that's had such a study.
Right. Why is it, do you think, that these numbers are not getting picked up? Let's start with the economic costs. are they just sort of too hard at the moment? You know, you talk about the now or later issue. Well, right now we do have deaths. Later, we've got estimates of loss. Now, most people are instinctively going to say, "Well, I'll worry about the later." You know,
yeah, I mean, I think that's. I mean, we're built that way as human species, right? We react to what we see in front of us, and the idea, the deaths that are going to come from the economic harm are just abstract. I think that's part of it. There's the psychology of like seeing what you see now, but that doesn't make what's going to come any less real, mind you. Those deaths are still deaths. The other thing is, I think there's been sort of facile moral argument that people sometimes make against people who are skeptical of lockdown, as if somehow because we're pointing out the economic harm that we think that the economic harm outweighs the deaths now. That's not the argument. The argument isn't. I mean, I don't know what the value of life is, dollars per value of life. I mean, I know there's a big literature on this, but I personally have absolutely no idea what it is, and I don't actually care what that number is. What I care is we need to adopt a policy that improves the health of the population in the long run. We shouldn't look back and say, okay, we saved these lives, but we killed all these. We in effect killed all these other people by our policy. But that's exactly what we've done worldwide.
Well, what was interesting about your slide with flattening the curve versus pushing it out was that, you know, it's exactly the same number. I don't think people quite appreciated that. How do you think that it's possible that countries like New Zealand have shifted from the idea of flattening curve to trying to eliminate the virus? And is it possible to eliminate the virus?
I don't think it's. I think a disease eradication. We've eradicated a single disease, a single virus. We've eradicated smallpox on the face of the earth. That took 30 plus years, and an enormous amount of effort, and a very, very effective vaccine. But we don't have those kind of conditions, and this is not smallpox. Most of the people getting it are going to have a relatively mild illness. They won't even know they had it.
Right.
This disease is not eradicable. It's an incredibly infectious disease. For most of the people that get it, it's relatively mild. For a few unfortunate folks who get it, it's very, very severe. Luckily, we now know who's most at risk. So a policy designed to protect those people, make sure nursing homes are bubble zones that no one can where the virus has no chance of entry. Right? If a country just does exactly that, it will have a much better outcome than, say, New York did or Italy did. Or, you know, I mean, I think if we've learned a lot also how to treat the disease better. So I think in the early days we were mismanaging patients with ventilators. We've learned, for instance, about the use of steroids to manage patients in ICU settings, to avoid cytokine storms or to treat cytokine storms. We're getting better at managing, and maybe the vaccine will come up. Now that's an actually interesting point I wanted to address also.
Sure.
The vaccine thresholds are for whether a vaccine is declared effective. I think now it varies from study to study, but I've seen numbers like it has to be 50% effective. Okay, that would be great to have a 50% effective vaccine. You can't eradicate the disease with that. You can't eradicate disease with that, with universal vaccination. Even with a vaccine, New Zealand will get, if it opens up to the rest of the world like it used to have, it will get cases. You will get cases, and if you close the world down, if you close New Zealand down, every single time there's 10 cases, you're going to keep doing that forever. It's never going to end.
So, final question. I'm asking everybody, what's the solution for New Zealand specifically? In New Zealand at the moment, Sweden's come back in as a possible approach for us to take. But there's a lot of talk about Taiwan as a model as well. I wonder if you can tell us the difference, or whether either of those is suitable for what we're.
It's polar opposite. I mean, I think New Zealand, I think, has taken an approach closer to Taiwan's. Mm-hmm. Right. So if I fly into Taiwan, I'll be quarantined for 14 days presumptively. They have an app you put on the phone, and I'll be mandated to put on my phone that tracks me. I'll have to check in every morning for every foreign visitor. The life, actually, I think for the most part outside is open. Although I think Taiwan, there's more universal masking than there is in New Zealand. There has been in New Zealand. So in a sense, you all have taken the Taiwanese policy. You've lived it. Maybe a little less enforcement of some of the restrictions that Taiwan has had, but roughly. Sweden, by contrast, I think in the early days, their mistake was that they didn't protect the nursing homes as well as they could have. I think they learned from their mistake, and they've adopted almost no mandated social distancing policies, no mandated lockdown at all. There was actual social distancing, voluntary social distancing, because people were justifiably scared of the virus because they didn't, we didn't know how deadly it was. So it's not like there was nothing that happened in Sweden. But it seems reasonably clear that in Sweden, the virus's spread is pretty much as far as it's going to. There may be pockets of people who haven't been exposed, but it would be very surprising. It's possible that they're through with the epidemic altogether.
Right. Okay. Mm.
It came at a deadly cost, though.
Yes.
I mean, they had many deaths. The question is, they paid those deaths and now they're done. So like the same thing in the United States. New York paid those deaths, probably more than it needed to because it didn't protect the elderly population. And their cases look low. Is that a success or a failure? And you be the judge.
Mm. One final question, if that's all right. One of the reasons that our Plan B group is here is to hope that we can learn from this and perhaps not take the same approach next time, that we can be prepared with something more subtle. Do you think we can learn from this event, that the world can learn, governments?
I really hope so, because I think this response to this epidemic was unprecedented in human history. The whole world shut down, the whole world locked down, one after the other, on the basis of almost no evidence. You looked at what happened in China, and in effect, I think we panicked.
Yes.
In retrospect, we need to set in place processes that make a response like this much more difficult, at least much more based on actual data as opposed to guesses. I think we have to take a very careful look at the models that led to some of the predictions that they had, because I think they were they provided a very misleading picture of where the epidemic was going to go. And I think the other thing is that we can put in systems that give us better information much more easily than you might think. So why is it that there hasn't been systematic seroprevalence studies everywhere all the time over this? This is something that I would think the disease, like in the United States, the Center for Disease Control could do. The health agencies all around the world could implement. Health agencies do surveys all the time. Why not have a panel of people that you go back to over and over again, draw a little bit of blood and do and it doesn't have to be seroprevalence for antibodies. Whatever the key statistic is, or the key set of statistics are, let's track them. Instead, we have all around the world this haphazard system of case reporting, and the cases we know are not the number to look at. What I look at is how many people over 70 get the disease, how many people have died from it over 70, how well are the hospital systems doing, are they overwhelmed? Those are the kind of statistics I think would be, if we looked at those from the very beginning, we'd have better policy.
Actually, I do have another question. Sorry, Simon Thornley has put a question through. He's saying skeptics are possibly pointing to the high overall mortality peaks recently, which contrasts with the low infection fatality ratio calculations. What have you got to say about that?
Maybe I can. I'll try to find Simon's question, but I don't fully understand. So the question is: are the total number of deaths are high?
Yes.
How does that square with the infection fatality rate? So, I mean, the total number of deaths is the numerator. The question is how many people have got the disease is the denominator. So the infection fatality rate is you're trying to get an estimate of that total denominator. The problem with the case fatality rate is you're just looking at a set of identified cases and you say, okay, this fraction of those have died. Well, if these numbers of people have died, but only this number of people got the disease, you're going to get a very high fatality rate. But if this number of people, the same number of people died, but this number of people got the disease, well, it's not that deadly a disease. So the question is, how many people actually got the disease? Oh, Simon, you're online. Can you clarify the question?
Jay, yeah, I guess the skeptics for me often come and say, well, the overall mortality in a particular country has a peak. And so that suggests that that's more than that what's happening with COVID is more than what's happening with past influenza viruses or.
Oh, it is, Simon, is more deadly than the influenza virus. Especially for people over 70. It is more deadly than influenza. I think based on the IFR numbers, it's at least 2 to 3 times more deadly than the deadliest influenza epidemic in the last, I mean, not counting the 1918 epidemic, which I think was more deadly than this. It's certainly in the last 50 years.
Sure, okay. Thanks, Jay.
All right, Jay, thank you very much for your time. Really appreciate it. And also the effort you put into to put that data in about New Zealand. I really appreciate that as well. Thank you very much.
Yeah, my pleasure. Thank you for the invitation.
Great.
And thank you for the question.
Okay, everyone. We have a couple hundred people, both participating and in on the YouTube, which is fantastic. Can I ask any of the panel members, if you're there and available during the day, feel free to answer some of the questions that are coming up on the Q&A, because we're not going to possibly answer them all. So you can answer them directly. Now we're going to take 15 minutes break. You can go into your kitchen and grab yourself a cup of coffee or something, or tea. We're going to do the same thing, and we're going to be back at 11 o'clock with Byron Brittle. All right, talk to you soon. Thank you.